Resident and fellow education is an experiential, workplace-based model of learning, teaching, and assessment that mostly happens in clinical settings. This doesn't change with competency-based models such as CCC or competence by design. Because postgraduate education occurs in approved clinical settings which have oversight of clinical care and involves university-appointed faculty and learners, a partnership model is essential. Broader partnerships, such as those with the regulators and PARO, are also important at a systems level to help make CBME work. There are 4 local partners in competence by design implementation. The first is the residency program, which includes the program director, but also learners, learner representatives, program administrators, key program committee members, and site directors. The second is the academic department, which includes the Vice Chair of Education, division heads, faculty development leads, and the CBD administrative support personnel. The third partner is the clinical training sites, such as our affiliated hospitals, including physicians and practice plan leads and hospital leadership. In fact, successful implementation of competence by design will require the engagement of the entire healthcare team. The fourth partner is the PGME office, which includes the PGME Associate Dean, the Education Integration Group, Faculty Development Lead, and all the people working on IT implementation. There are numerous partners outside of the local environment. The first are our national accrediting colleges, the Royal College and the College of Family Physicians of Canada, who set the standards and provide resources to guide us. Then we have our research partners, locally, nationally, and internationally, who study what we do and help us understand some of the best options for implementation. Our national colleagues, the 17 postgraduate deans and CBME leads, collaborate and share regularly as we develop new and different solutions for implementation. We also collaborate with a large number of provincial partners, the CPSO, the CMPA, the Ministry of Health and Long-Term Care, CAHO, and PARO to help adapt to the change.
Effective implementation of competency-based education requires the consideration of 2 important and connected elements. Firstly, the residency program must meet the approved national specialty requirements, and secondly, must also reflect the realities of the local program needs. How a program is locally implemented depends on a wide variety of factors, such as the length of the residency program, the numbers of learners, faculty, teaching sites, IT platform used.
Local customization is important for competence by design implementation because although we have broad national constraints we have to work within, it's really important to recognize local context and the unique environment here at the University of Toronto.
The local CBD implementation process includes having the program director and administrator meet with the postgrad team over several months working through key activities. The first activity is completion of an intake inventory that takes stock of what the current residency program looks like and sorts out what parts of the past program will be kept, renovated, or deleted. The activities that are part of the CBD design phase include the planning and mapping of the required content into high-level curriculum maps and assessment plans.
For the preparation of implementation of the CBD during the last few months, so what I learned basically mainly 3 things. The first of all, I had to learn and then find out what is best suited for our university and the program. And secondly, I have to find out what other programs and other universities they have done in similar setting. And then thirdly, we modified what they have done in other universities and programs in forensic pathology, and we modified it best suited to our university and the program with the help of Postgraduate Medical Education Office. And I think we have to reevaluate the way how it goes and then make changes accordingly to make it better.
Next, the CBD development phase includes activities for the on-the-ground implementation, such as assembling new and revised assessment tools, developing competence committee procedures, and updating the site-based rotation plans and learner schedules to reflect the new requirements.
It's been important to me as program administrator to be part of the planning for CBD implementation because oftentimes the faculty and the program directors look to me to give them a sense of all of the moving parts of the program. I've enjoyed coming to the planning meetings because it gives me a sense of the homework that we need to do afterwards, as well as a sense of the overall implementation plan of CBD. I also feel that it will allow me to answer any questions that may arise from either faculty or learners.
Planning for CBD integration and delivery involves the development that faculty and learners will need for CBD. Additionally, there needs to be early consideration of how and what will be part of CBD program evaluation. Early check-ins with residents and faculty are important to allow for improvements and adjustments to CBD implementation.
So when I talk to program directors who are implementing CBD, the first thing I say is start field testing as soon as possible. Field testing allows the faculty and residents to alleviate a lot of the apprehension that they may have developed and work through how they're going to incorporate these assessments into their busy clinical practices as the full launch approaches. The second thing is spend a lot of time on resident development, not only on the mechanics of CBD assessment, but on how that information will be used to make decisions about how they pass through the different stages of training. Also, we found that the time you spend working with residents will really pay off because residents will become some of your most important faculty developers as they share what they've learned with their busy supervisors.
As we move forward with competence by design implementation, I think it's really important to keep in mind just how big a change this is. This is one of the biggest changes in the last century in medical education for both specialists and family medicine. I think we need to be flexible in our implementation. Although we have a national framework to work with, how it plays out locally is going to be very, very important, and we have to respect both the end product of CBD, but also faculty member and the institution's ability to accommodate change. We'll do our best to get it right, but we have to recognize that we will capitalize on things that go well, and we will study it and identify things that don't go well, and we'll put in strategies to improve along the way.